Well, welcome everybody to the GU block of CAGLA 2025. For those of you who don't know me, my name is Dr. Brian Halbert. I am a medical oncologist at the Ochsner MD Anderson Cancer Center here in New Orleans, and along with Dr. Rose, who's been chairing this session with me, we are pleased to get you guys here today. We have three fantastic talks here today, looking at some areas of genitourinary malignancy that traditionally haven't necessarily been in the spotlight, looking at penile cancers, surgical management of seminoma, and biomarkers in RCC. So our goal here today is to hopefully illuminate some of the advances that have been made over the last several years. And if we do our job well, you guys can hopefully take something home with you to understand how you can use your voice to really move care forward for our patients. Before we get going, though, I do want to take a minute just to reflect on what we are doing here with CAGLA. We all know that the scientific advances for the prevention, diagnosis, and management of cancer, these advances are coming at a breakneck speed. But, whether it's for every single advancement that comes, there is unfortunately an equal and opposite obstacle that comes for many of our patients, whether it's accessibility of care, whether it's disparities within our community, or if it's medical or financial toxicity. We've also seen over the last several months, for better or worse, the changes that have happened in our country. And regardless of how you feel about some of these changes, I think there's something that we all need to understand. And it is on us now, as private individuals and private organizations. We are the ones that really have to drive forward, identifying and removing these obstacles. Chad said it last night at the cocktail party. He said that the C in CAGLA does not stand for complacency. And that is 100% true. Now is not the time for us to sit back and wait for the American healthcare system to fix itself. Nobody is going to do that for us. It's on us as CAGLA, and that's what this organization can do. Chad also said this morning that maybe the C could stand for community. And that's what we are. We are a community of people from across the healthcare system. We have a complete variety of backgrounds and professions and expertise and experiences, and we all bring our own individual opinions and ideas into this space. But we are all united as a community, understanding that the lives of our cancer patients are worth fighting for. So please, please, please stay with us as we continue that fight. First up, I'm going to invite Dr. Rose up here, who's been chairing this with me, to give the first talk here. Dr. Rose is originally from New Orleans. He grew up in Lakeview. He did his undergrad at LSU, where he was on the track and field team there. That's always one of my favorite things about him. I don't know if you guys know the pole vaulter Armin Duplantis, apparently the best pole vaulter ever. Second best behind Kyle, is what he's telling me. Now, Kyle says he taught him how to pole vault. But from LSU, he went on to LSU Shreveport to get his medical degree, and he did his general surgery and urologic training at Mayo in Arizona before going to Moffitt for his urologic oncology training in Tampa. We were fortunate enough to have Kyle join us, where he's been a real force to be reckoned with in the urology department here at Ochsner, really bringing a lot of expertise into bladder cancers and to testicular cancers, which I think you guys will hear from him today. So Kyle, if you want to get up here. Oh, I also wanted to say, I had the pleasure of being on a Mardi Gras float with Kyle this year. And he is so dedicated to his craft that this man brought flashcards regarding prostate cancer management onto the float. And I threw those cards in Bacchus. So if you were on the Bacchus parade throughout this year and you got a flashcard about prostate cancer, please return it to Dr. Rose. He needs them.
Thank you, Brian. That's extremely well said, by the way. Thank you very much for that. And you ruined slide 13 for me, so we can just skip that now. But it's a pleasure to be here today. Good afternoon, everybody. Thank y'all for having us. We're going to talk about the expanding role of surgery in seminoma. Y'all have seen me speak before, most likely, so we're going to break up the slides with some little funny pictures, things that will keep everybody engaged. These are my financial disclosures. Sorry, I feel one's going out, the other's going in. And the picture bottom right is where all my finances go. So seminoma simplified. I have found as a resident, as a medical student, seminoma, germ cell tumors to be very intimidating to learn. But they are the most common solid organ cancer for men who are 15 to 35. Overall though, pound for pound, they're extremely rare. It's only about 1% of all cancers. So today we're going to be talking about pure seminoma. And as we enlist exactly what that is, it's a germ cell tumor, seminoma only. AFP is within normal limits. And there's no additional germ cell tumor components. Otherwise, we treat that patient as a mixed germ cell tumor along the non-seminomatous germ cell pathway. When we talk about a primary RPLND today, these are patients who have enlarged lymph nodes in the retroperitoneum, and they are undergoing surgery prior to getting any sort of chemo or radiation. In other words, this surgery is being done with curative intent. Now, there's always a role for surgery or XRT afterwards, but one of the benefits here is it decreases the sites of recurrence for this cancer. One of the common themes we'll be talking about today is the rate of PN0. So we take a patient in the OR, we resect their lymph nodes. There's no viable cancer in those nodes. And so you might think as a patient, that's great, I don't have cancer. But for me, it somewhat hangs over my head because we've put you through a monster surgery and we don't know if you benefit or not. Do you want me to turn this away? Check. Oh, perfect. Thank you. So, there's certainly this paradox in surgical oncology. If somebody is T0 or N0, you might think, great, we don't have cancer. But for me, a surgeon, knowing the risk that we put you through, that's something we have to consider, right? Because we don't know if we actively helped you or what your outcome would have been without surgery or chemo or XRT. This is why testicular cancer is intimidating, because when you look at the cookbook that is the NCCN, there's several different stages. You have to take into consideration the primary tumor, their lymph node status, the presence of Mets, and their serum tumor markers. So I think this makes seminoma, germ cell tumor, very unique among different types of cancers. So as a surgical principle, just to really simplify what we'll be talking about today, I'm a simple guy with a simple mind. As a principle, we rarely operate on serum tumor positive patients. Most of these patients, or all of these patients that we'll be talking about on trials, were marker negative. Stage 1 is typically confined to the testicle, and stage 2A, 2B, which is primarily the patients we're going to talk about today, have spread to the lymph nodes in the retroperitoneum, typically less than 2 centimeters for a N1 patient who's stage 2A, or 2 to 5 centimeters for a stage 2B who's N2. And there's a couple of caveats to that, which we will go through. But the retroperitoneum, this is the site that we are primarily exploring. This is an area that is, I think, questionable and concerning for us as surgeons. There's a lot of important structures in here. These are the 2 largest blood vessels in your body that course through this tract. And so in order to do this surgery properly, we have to skeletonize those, take all the lymphatic tissue off of them, and try not to injure any of them. And what's not shown in this photo is all the internal organs we have to get out of the way in order to get there. This is a surgery we perform frequently at Oshner. Both Dr. Arcott and I are extremely grateful for this. These are some of the pictures of the RPLNDs that we have done. In the top right is a non-seminomatous patient that Brian actually helped us with, and Dr. Arcott and I had performed his surgery. And then on the bottom left, it's the same patient, and you can see there at the bottom of the photo, there's a patch graft on the cava. So that case took about 5 years off of our lives. We can also do the surgery on the robot. There are benefits to that when it can be safely done. This patient was able to go home on post-op day 1. In the top right picture, you can see there's a loop that's around one of the nerves that we have spared during his case. And then in the bottom right is a post-chemo seminoma, which is a bit different than what we'll be talking about today, but those are traditionally very sticky, very tough, and can be very humbling. The reason we're so interested in the retroperitoneum is that mapping studies have been done analyzing where the spread is from the right or the left side. So if you had a right-sided tumor, if you had a left-sided tumor, the likelihood of that passing over to the right side of the retroperitoneum is actually extremely low. This was done by John Donahue from Indiana in 1982 through these elegant studies. On the right side, however, right side can cross over to left, and I would commit this as a student just over and over. Right goes to left, right goes to left. And so these lymph nodes, we have to expand our template to include the left side when someone has a right-sided primary in their testicle. This is one of my first break photos. I'll apologize to Dr. Arcott, but this is my favorite photo of Ro. This is my caller ID for him. We would always stop by each other's offices and chat, talk about our cases, talk about weird cases we saw that day. And so this day he came in, sat down, and he had a Snickers ice cream bar in his hand. I said, "Oh no, what happened?" And everything was fine. But it was just a great picture, and grateful to work with him, and that we get to share these patients with testicular cancer together. The stepwise spread of seminoma is very well established. So seminoma, unlike non-seminous germ cell tumor, typically does not skip the retroperitoneum, whereas 10% in non-seminoma can. There's benefits to this surgically. So that if we stage somebody and we remove the lymph nodes of the retroperitoneum, the likelihood of them having skip mets is extremely low, and in several studies, it's 0%. And so this gives us good confidence in some of the studies that we have done and some that I'll present today. The big scary blood vessels are not the only thing in the retroperitoneum, though. The sympathetic nerves are also back there. And these are postganglionic sympathetic fibers. And when we think back to med school, we're taught the old point and shoot. So parasympathetic is erections, shoot is sympathetic, and it's ejaculation. So if those nerve fibers are sacrificed during this surgery, patients can have a relative infertility. Now, they still make sperm, they're still viable sperm, but their ability to naturally conceive changes. And that's important to counsel patients on. And the right or left side of these has been studied extensively. And we'll go into some of the nerve-sparing studies that have been done for seminoma. This was a study, just a great example done out of USC by Dr. Don Skinner. They had used RPLND for low-stage testis cancer, not specifically seminoma or non-seminoma. But 47 patients underwent nerve sparing. 81% recovered their ejaculation at 12 to 24 months postoperatively, and it was better with right-sided than left-sided tumors. No patients, importantly, had a retroperitoneal recurrence. And so what this tells us is that in experienced hands, nerve sparing is safe to do when we are not compromising the oncologic benefit from surgery. To understand where we are and where we're going in seminoma, it's important we understand the history of this. So 1959, Patton and Hewitt from Walter Reed Center. 510 young men with testis cancer treated patients with seminoma with an orchiectomy and radiation. 95% cure rate, which is awesome, right? Those patients were followed somewhere between 1 to 3 years. There were low complications or issues after the XRT. And then fast forward another 10 years from Roswell Park Cancer Center. Dr. Bochter, 414 patients with testis cancer. Seminoma patients were treated with orchiectomy, followed by either RPLND or radiation to the nodes. The short-term morbidity in those patients was worse with surgery, and so XRT became standard of care. That was 1969. These studies were primarily looking at the short-term outcomes of these studies and looking at overall survival, not necessarily the long-term complications. And I bring that up because this is a study of 40,000 patients who underwent treatment for testis cancer. Average follow-up of 11 years. This was looking at the long-term toxicity associated with that. In seminoma patients, the risk for secondary cancers after XRT, so 1975 and over, that's when XRT became the standard of care. They had a significantly higher risk than the general population and non-seminous germ cell tumors. What was their risk? It was double. They had twice the risk of a second primary at 11 years follow-up, not even looking at 20 to 30 years after, but double the risk for a secondary cancer. And this is with XRT, okay? What about for chemotherapy? Well, if we look at cisplatin, which has been our cornerstone for seminoma treatment, we find issues with patients' nerves in 30% of patients, and ototoxicity of up to 80% patients on treatment, and long-term, that's 25% at 2 years. We already described the secondary cancer events, but also cardiac issues. These patients had a almost 6 times higher rate of EVD compared to the general public. So these are risks that we have to be counseling patients on. And keep in mind, these are patients who are 25 to 40. We're not looking at necessarily the next 15 years. We're considering the next 50 years, the next 40 years. And so we have to take into consideration what the alternative treatments are. Here you go, Brian. This is for you. So this is a picture of Dr. Halbert and I at Bacchus. This is our getting ready room. We'll give you extra credit at the happy hour if you can tell us what we're dressed up as, because we still don't know. But I was studying for my boards. I brought my flashcards, which Dr. Brian said, and I specifically saved the advanced prostate cancer for Bacchus Sunday. So if I had any questions, just ask Brian. And as the day goes on, he's tolerating it. And then as we indulge in the cultural festivities of our great city, eventually he turns to me, he's like, hey man, I'm going to throw some of those. And I was like, you're not going to throw them. I got to study these. I don't know this stuff. You can't throw them. So we made a pile of the stuff I knew, and those are on St. Charles Street right now. So if you pick up any advanced prostate cancer cards, you can thank Dr. Halbert for that. So what are our current guidelines for seminoma? So patients have generally 4 options, or really a combination of 3. So they can go to radiation therapy. They can go to first-line chemo with bleomycin, etoposide, or cisplatin, or they can undergo a nerve-sparing HARP-LND. And we'll go through some of the data that I will present in terms of the pros and cons of each, specifically focusing on surgery. What I would really mention here is that in the US, this is the NCCN guidelines, we like to risk stratify these patients not just by 2A, 2B, but the size of the total nodes. So lymph nodes less than 3 centimeters, you're a candidate for surgery. Lymph nodes greater than 3 centimeters and you're still N2, we like to lean more on chemotherapy preoperatively because the likelihood of curing those patients with surgery alone decreases. The first trial I'll present is the SEMS trial out of USC. This was analyzing patients with low volume Mets, clinical stage 2A, 2B. They limited the study to patients with less than 3 centimeters nodes in size. They used a template, meaning that they did not go to the full right to left side during their surgery. And they accrued 55 patients, which is the largest of the trials that we will cover. On final pathology, seminoma was present in 82% of patients. The rate of PN0, so patients with no evidence of cancer, was about 16%. They had a follow-up of 33 months, and 22% of patients recurred. Overall, very good outcomes, 100% overall survival at 2 years. In the patients that recurred, 8 recurred in the retroperitoneum, 5 were in field, meaning that it was an area that should have been dissected and they recurred in that spot, okay? 4 patients recurred in the pelvis, which is out of field. That's not our typical template for patients with testis cancer. As your pathologic node stage increase, the recurrence-free survival decreases. So patients who are PN0, 100% recurrence-free at 2 years. And the authors noted that the PN0 rates occurred exclusively when the lymph node size was less than 1.5 centimeters. So why can't we use 1.5 as a better cutoff to select patients for surgery or chemo? That would miss about 69% of patients. So we can't necessarily just move our threshold to 1.5. Anejaculation occurred in 3 patients, all of which had a non-nerve sparing surgery. So overall, the authors conclude there's a good role for RPLND in early stage cancer. Recurrences occurred in the retroperitoneum, pelvis, and chest. Overall, there's about a 22% recurrence rate. All of those that experienced a recurrence were then salvaged with second-line therapy and were free of tumor at their follow-ups. The side effects of surgery is very well tolerated. These are all done by very high volume centers, no blood transfusions, 1 incisional hernia. The patients with sexual function issues, they all had non-nerve sparing surgeries. Again, we don't want to compromise the oncologic benefit of surgery. A similar study was done out of Germany in 2022. This was the PRIME test study. And again, I had harped on the NCCN guidelines versus the EU guidelines. And this is slightly different. It's stage 2A, 2B, but they allowed lymph nodes to be up to 5 centimeters in size. This is a slightly smaller study, 33 patients enrolled. 9 patients were primary, meaning they were treated right off the bat after their orchiectomy. 19 patients were previously on active surveillance, Brian, like that gentleman you told me about. And importantly, though, 58% of these were performed on the robot, which is slightly different than what I would consider, most people consider the standard of care for this type of cancer. At a median of 32 months follow, 10 patients had recurred for about 30%. The infield recurrences occurred in 3 of those 10 patients. 9% of patients were pathologic and 0. The authors concluded that almost all recurrences were in the retroperitoneum, yet mostly outside of the field except for those 3. They had an estimated primary endpoint for recurrence-free survival of 90%, which was not met. But the authors also admit surgery had a low complication rate on trial. There's a favorable progression-free survival. Of the patients that were PN0, keep in mind, they're still clinical stage 2A and 2B. Those patients would otherwise still get chemo-rads. And so we have at least spared them from that. We've decreased the sites of recurrence, and we can tell them with confidence that they were PN0. This is my last fun slide. So this is Dr. Davey. Dr. Davey is my chief resident, he's my PGY4. He's going to be a chief resident next year. Connor is from Oklahoma. So he came down here, and Sean Collins, who y'all may know, took us duck hunting, and Connor's never been duck hunting before. So we decided to mess with him a little bit. And we told him, like, listen, man, a duck can see your little face pop out of a blind from a mile away. Don't ruin this for us, okay? And we hustled him a little bit. We gave him a little attending pressure and told him that, like, wake up in the morning, brush your teeth, put your clothes on, face paint on, let's go. Don't mess this up for us. And then he came downstairs. There's about 30 guys, and he's the only one with face paint on. But he handled it like a champ, and we're extremely proud of him, and we're excited to have him on board as our chief next year. And believe he'll be going to Oklahoma, Kansas City, right? The last trial we'll cover is the COTRIMS trial. This is also out of Germany. This was more recent, done in 2024, published in EU Oncology last year. This is for clinical stage 2A and 2B Seminoma, similar sample size of 30 patients, shorter follow-up of 22 months, 11 patients previously on surveillance. Instead of using a robotic technique, these were primarily done open with nerve sparing. So 27 underwent open surgery with nerve sparing, 3 were done on the robot. This is one of the first prospective trials to use a microRNA 371 circulating tumor marker. So seminoma was present in 80% of the specimen. 3 patients were PN0. 3 patients had recurred out of field. All of them were salvaged with chemotherapy afterwards. The authors had concluded it's a safe alternative to chemo-rads. The recurrence-free survival was 90%. Smaller study, shorter follow-up, but better RFS. Overall, with surgery, there's a low complication rate. And what's important and what's exciting is that microRNA 371 predicted benign disease in all patients. Keep in mind that's only 3. And it predicted disease in 92% of patients. So is there a role for this circulating tumor marker to better select patients for surgery preoperatively? When you compare these 3 studies head to head, we find that the recurrence-free survival is approximately 80% in experienced hands. The complication rate is low, again, experienced hands. The pathologic N0 rate is somewhere around 10 to 15%, okay? In the patients that did recur, they were either salvaged with additional surgery or with BEP chemotherapy. So there are several options available for patients who recur, who have excellent outcomes. So in conclusion, RPLND, the recurrence-free survival is good. It's not perfect. And we're constantly trying to identify areas in which we can improve. How do we decrease the recurrences? How do we decrease in-field versus out-of-field? You know, part of doing a template is that we spare the contralateral side, and importantly, we spare the nerves. But if patients are recurring in the contralateral side, should we expand the template? If we expand the template, that changes the complication rate with surgery. It changes the sexual function after surgery. Should we include their pelvic nodes? In the SEMS trial, they had 4 patients that had recurred in the pelvis. That's completely out of field. And so should we expand our template even further to include the ipsilateral pelvic nodes? Overall, though, RPLND must be weighed against the risk of long-term toxicity of chemo-rads. Remember, these are patients who are on average 25 to 35. We're not thinking about the next 5 years. We're thinking about the next 30 to 40 years. There's a role for salvage chemotherapy in surgical failures or patients that recur distantly. We need to better select patients who may be PN0 and identify those patients that are at higher risk for relapse, even though we think we got it all. There is a significant role for precision medicine and microRNA in these patients. We need more prospective, larger scale studies to confirm that. To my knowledge, these aren't on the market yet, but it looks extremely promising and very special for this type of cancer. So with that in mind, I wanted to thank everybody. Thank y'all for having me. I'll answer any questions that you may have.